Hello and welcome to another lecture for my class, PSYC 770, Psychological Testing and Assessment. As you can see from this title, today's lecture will involve interpreting the Beck Depression Inventory 2nd edition, or the BDI-II. Now, if you have any experience with the BDI, you may be wondering why I would bother to devote a whole lecture to just the interpretation of this seemingly rather simple instrument. But I think if you stick with this and pay attention to some of the stuff I have to say, you'll find that the Beck Depression Inventory has got some additional levels or layers or nuance that make it really fascinating to learn about and actually quite useful to use. So with that in mind, let's take a look at the overview for what I'm going to talk about. First, just some really quick advice and instruction on how to complete the record form. Then some suggestions about some basic interpretation. And finally, just an attempt to put it all together. And the important point I guess I'm trying to make, like the meta point for this lecture, is that even simple measures are worth studying. Because they give us opportunities to review key concepts from our classwork and give us opportunities to learn how to use a measure or a test the right way. When we get on to more complicated tests, all these same issues will apply. So it's good to learn on something that's relatively simple, but as I suggested a little bit earlier in this lecture, something that has its own level of complexity, and the Beck Depression Inventory certainly does. So first off, completing the record form. Well, this is pretty easy. Just on the front page, there's information to identify the patient or the client or the participant in your study, whatever, and there's a place to fill out the date. Things like the test taker's name, marital status, age, sex or gender, occupation, education. The important point I make here is don't forget to complete this information. It's important for identifying the client, and one of our professional standards as psychologists is to maintain good records that are kept appropriately private and confidential, but good records nonetheless. The worst thing as a researcher or as a clinician is to come across a stack of instruments, a stack of tests with poor or incomplete identifying information, because then you think, gosh, who are these people? Is it all the same person? Can I use this information? Can I make sure that I can adequately protect the person who filled out these various forms? Don't get into that type of situation. Just take the small amount of time necessary to make sure that you or the client or the participant or basically the test taker fills out that information. Then the front and back pages of this test, as you probably know, because you've probably seen it before, are just a set of questions. The test taker fills out those questions himself or herself, and once they're done, your job is just to double check their responses. Make sure that everything is clearly indicated, and make sure that all the items are complete. If not, ask the client to give his or her best answer. So if the client skips an answer, it's appropriate, at least as per the technical manual for this instrument, to encourage them to fill out a response. There will be cases, of course, where a client or a research participant will refuse to answer a question, and that's all right. You certainly don't want to force someone to answer, but if they've overlooked an item or if they've maybe hesitated, it is appropriate, again, as per the test manual, to encourage them to give their best answer and remind them that their job is to reflect upon the past 2 weeks. So for instance, if they're really struggling to answer a particular question, and you get the sense that maybe they're thinking across their whole life, just remind them gently, this is just for the last 2 weeks. Which of these responses for this item best reflect how you've been feeling for most of that time? As you're looking over the person's, your test taker's responses, you might want to pay special attention to item 16, which is for appetite, and item 18, which is for sleep. There are 7 options for this response, and that's different for the other ones, which have only 4 options. I think I mentioned in a previous lecture the response format on the BDI is called a Gutman scale. It basically involves groups of responses which escalate in their severity from the lowest to the highest. For most of the items on the Beck Depression Inventory, there are only 4 options. For these 2 items here, there are 7, and so you just want to make sure that the client has picked just one. They haven't, maybe out of confusion, circled a couple, and if that's the case, you ask them to choose the one that fits best. And it's also important, maybe for more clinical or diagnostic purposes, to pay attention to disruptions in appetite and sleep, because as you well know, they can accompany various forms of psychopathology, including depression and in some cases bipolar disorder. You might also want to pay attention to item 2, which is hopelessness, and item 9, which is suicidal responses. Now, these items have their high scores are 2 or 3. They go from 0, 1, 2, and 3, 4 possible responses. And if someone has answered it in the 2 or 3 range on either of those items, you definitely want to make a note of it for clinical purposes. At the very least, you should follow up on indications of suicidal thoughts with a more thorough and more careful assessment of someone's level of suicidal threat or risk. You should also look for extreme responses. For instance, if someone selected all the lowest possible responses for every item, they put 0 for everything. It could be possibly that they're minimizing or denying problems. I mean, they may be being entirely honest, but it's also possible they're minimizing. If someone answered all 3s, or basically the highest possible response for each of the items, they could be maximizing or exaggerating problems that they're having. Again, it's not entirely clear. They could be being very honest, but you certainly want to consider the possibility of problematic responding in those types of cases. Why do clients have extreme responding? Well, some clients show evidence of dichotomous thinking, or what this is sometimes called, where they kind of think of themselves as either being entirely good or entirely bad, or maybe more precisely that things are going entirely well for them or entirely horrible for them. Again, this could be kind of an honest reflection that a client is making about himself or herself, or it could be evidence of this sort of what psychometricians sometimes call a response set, a characteristic way of responding that a particular test taker will apply to almost any situation. Some people are yay-sayers. They tend to endorse yeses a lot, regardless of the question. Some people are naysayers. Some people have this rather dichotomous way of thinking. If we want to get really fussy about this, we can consider this a form of measurement error. But the basic idea is, if someone's responding entirely in the lowest possible range or entirely in the highest possible range, you should at least consider the possibility that what you're looking at isn't an honest reflection, but maybe a distorted reflection, which is not to necessarily say dishonest, but just a distorted reflection of how that person really feels or thinks or tends to behave. Extreme responses could be a real feature of depression. Again, this kind of dichotomous thinking can occur independently, but could also be characteristic of someone who's had prolonged depression. Depression can be in some ways limiting in people's cognitions. They can come to think of themselves, of course, as entirely bad. Everything's entirely wrong with them, or that there are times when they're entirely good. Again, this could be truthful or real responding. And according to the test manual, you are allowed to say to the person, the client, the test taker, the participant, that most people don't experience all symptoms the same way, and you are allowed to encourage him or her to reconsider his or her responses. So this is tricky, right? You don't want to be pushy about it, like, hey, I noticed that you circled all 0s. That's unusual. You should probably change that. Or, gosh, don't you think you really mean that you should have circled 1 for this item or 2 for that item? That wouldn't be good, of course. But a gentle, kind of encouraging and supportive bit of feedback, like, it's not common for people to answer entirely 0s. It's not common for people to answer entirely 3s. Would you like to think about those answers a little bit more before we move on? And the person might say, well, I was confused, or gosh, I guess so. Or they might say, no, that's how I feel, in which case, you move on. The back page of the instrument, as you probably know if you've seen one of these before, just has a space for you to total up the score, and the score for any person is just the sum of the number values associated with each of the responses that they endorse for each of the items on the test. And so it's just some simple math. Although, be careful, use a calculator if necessary. Don't mess it up. How do you interpret the Beck Depression Inventory? Well, here are some basic suggestions. We typically, and with most tests, this is the approach that I take, and I'm not just saying this like some idiosyncratic property of my thinking. This is the approach that's generally encouraged by most textbooks or technical manuals for most tests. And so the Beck is just a good example of this thought process. One is you begin with the most global measure that the test offers. And in this case, it's just the total score. Then you begin to go to successively finer levels of specification. So in the case of the Beck, we'll begin with just the total score as an index of overall level of depressive symptomatology. We might, if we want to, move beyond that to consider some cut scores. Does the person score within a range that's associated with a particular severity, or might almost want to say type of depression? We might want to go even further beyond that to consider factor scores. That is, if we subdivide the items into groups based on factor solutions from factor analytic research, can we extract scores to reflect different features or qualities of this one person's depression? And then if we want to go even more fine-grained, we might look at individual items and ask specific questions or make specific assessment inferences about individual items. So it's kind of like moving from global to local, or moving from general to specific is the thought process that we often apply to almost any test, and the Beck is just a good way of giving a simple example of how that might work. So, total score. Well, total score, sum up the items on the front and back pages, overall severity of depressive symptoms in the last 2 weeks. So if the person's answered honestly, if they answered correct to their own impressions of themselves in the last 2 weeks, what you get is a general index of their overall depressive symptomatology in that time. Pretty simple, right? What about getting a little bit more complicated and considering cut scores? Well, we can compare that score that an individual person has, or the scores of a group of people, to some cut scores. And you may be wondering, all right, well, we've talked about cut scores before. Where do these cut scores come from? Let's talk a little bit about the development of the Beck Depression Inventory. It was originally developed to compare a clinical sample that had been divided into diagnostic groups. People who had depression, people who didn't have depression. And back in the day, this was based on the symptom lists in the DSM-3R as reflected on the SCID structured clinical inventory. Now, the researchers who did this work used rock curve analysis, which I've discussed in a previous lecture, to develop optimal cut scores to separate non-depressed people from mildly depressed people, non- and mild depressed people from moderately depressed people, non-mild and moderately depressed people from depressed people, or I should say from severely depressed people. And if you watched the previous video, and if you thought a little bit about how I tried to describe rock curve analysis, you know that the basic idea of this approach is we're trying to balance sensitivity and specificity. We want the best probability of test positive given status positive balanced against the probability of test negative given status negative. And in rock curve analysis, there's no one absolutely precise way to do this, but we get a general sense, usually, that there's a best place to cut a score or place a marker on a continuum of scores. Why was the Beck Depression Inventory developed in this way? Well, the BDI and after it the BDI-II was developed in such a way to maximize sensitivity because it was seen principally as a screening instrument. The idea from the get-go was to develop a brief clinical instrument that would be good for detecting depression and wouldn't be that, in situations where it wouldn't be that big a deal if there were false positives. So you could imagine the Beck Depression Inventory being a little bit turned up in terms of its gain. It's a little bit liberal in terms of how it, in air quotes, diagnoses depression. So there are going to be some people who score in a relatively elevated range on the BDI who maybe don't meet full diagnostic criteria, at least in the DSM system, for depression. Those folks are false positives, at least from the perspective of their Beck scores. Maybe that's not that big a deal because if they were in a clinical setting, they would be referred for more careful evaluation and the false positive would be detected, and the person would be given a different form of treatment or maybe given no treatment at all. Again, in this context of screening, false positives, not that big a deal. False negatives are potentially worse. So we the thinking going in the development of this test, and especially in the sort of setting of these cut scores, was to avoid false negatives, because that could be situations in which someone had depression but was turned away because they didn't meet screening criteria. Their score didn't elevate above the necessary cut score, and in those situations the cost could be high. A depressed person who goes without treatment suffers a lot. A depressed person who's maybe suicidal could attempt or even die by suicide. You get the idea. The test was designed to be liberal, or to use the kind of the sort of metaphor and the words from radar analysis. It was developed to have a high gain, maximizing it risks maximizing false positives in an effort to minimize false negatives. So what are those cut scores? Well, here's what they are set out, or here's how they are set out in the manual. So 0 to 3 is kind of minimal or no depression. I think I noted in a previous lecture that if someone scores 0, by tradition we sometimes wonder if they're minimizing. I already pointed that out. They could just have little or no depression. In the range of 14 to 19, they're mild depression. In the range of 20 to 28, moderate depression, and 29 and above, severe depression. Now, it's probably worth committing these numbers to memory, just because you're likely to encounter the Beck Depression Inventory a lot. If you have any amount of trouble doing this, and Lord knows I sometimes do, I tend to think of it like anything less than 20 is at worst mild depression. Anytime the person's getting over 20, it's moderate or severe depression, especially if they're over 30. So 0 to 20, 20 to 30, 30 and above is kind of my very rough rule of thumb way of thinking about this, and that more or less comports with the published cut scores. You might be asking, well, what about different cut scores? You certainly could lower the cut scores if you wanted. I mean, if you were using the Beck Depression Inventory in a clinical setting, you might be maybe especially concerned about screening for depression because you think you have a high-risk population, or there's a lack of follow-on services, so you don't really don't want to miss people. You could lower those cut scores and thus increase the gain of the test. You'd have fewer false negatives, you'd have more false positives, but maybe that's acceptable if you're working in a clinical setting where that seemed right. Maybe you're working in a research setting where you really want to screen out people who are depressed because you're doing some sort of risky manipulation in the lab. You don't want to scare or sort of traumatize people. That maybe that's appropriate there. It's really up to you. Cut scores are not set in stone. They're just optimizations made for certain types of decision making in certain types of contexts. So, when we look in different settings, or I should say, I have looked for some research that's been done to evaluate cut scores in different sorts of settings, and at least the last time I checked, a lot of the studies that I saw found cut score solutions that were pretty similar to those offered in the manual, which is a good thing, because it means that generally speaking, if you have that sort of broad approach of wanting to screen for depression, and you use cut score, and you can develop cut scores to maximize sensitivity balanced against specificity, you get fairly similar solutions. So for instance, in a study that looked at psychiatric outpatients, they used the kind of 0 to 16 point to be not depressed, 17 to 63 to be mild or more depressed. University Counseling Center, 0 to 15 not depressed, 16 to 63 mild or more depressed. Adolescent outpatients, 0 to 14 not depressed, 15 to 63 mild or worse depression. Again, that's not massively different than the generic or rather general cut scores, and that's that's probably because the test works about the same even in these different populations, which is probably really a testament to the quality of the test, or the robustness of this test. And again, if you were ever kind of really pressed to come up with a quick guess as to someone's level of depression based on a BDI score, you might just generally think that if they're kind of in the single digits or teens, they're probably at worst mildly depressed. If they get much above 15, 16, or certainly into the 20s or 30s, then they're probably more likely to be moderately or severely depressed. So the important points maybe to make is that these cut scores are just ranges that are in the manual, and they tend to work. Other scores and other ranges might work better in some populations, and you certainly can check the literature. I did a while ago, and I found, as I tried to illustrate here, fairly consistent or fairly similar cut scores, but they're not set in stone. It's also important to note, though, that we really shouldn't be diagnosing people based on only the Beck Depression Inventory. It's not designed for that. It never was. It's a screening instrument. So if someone elevates, into the 20s or 30s on their Beck Depression Inventory, you don't skip the diagnostic interview and say, well, they're clearly depressed or severely depressed. That would be really not at all meeting the professional standards or the ethical standards that the APA or any good psychologist would encourage us to have. This is an instrument that should help us help us do our assessment, maybe ultimately help us make a diagnosis, but it's not the one and only thing you would want to use. You might ask about, well, what about different populations? I guess I used the word population already. I referred to like adolescent outpatients or, psychiatric inpatients. Those are in some ways of reckoning different populations. But if we think in a more common sense of population, like different ethnic or cultural populations, you see here on the slide, inpatient, outpatient, clinical, non-clinical. In general, the BDI has been used with a lot of different populations. It's a very well used and well studied instrument, and it seems to be pretty good. I sort of hinted at that in a previous lecture. Probably didn't give quite as much information as I really should, but you can feel, I think, fairly confident when you're using the Beck Depression Inventory that it's not going to change very much, or you're not going to be risking a great deal of test bias if you use it very much in one population and then apply it in another population. Just as an example, if you look in the Beck Depression Inventory, they actually publish some research. It's a good technical manual given how small it is. They publish, they being Beck, Steer, and Brown, the developers of the test, published some research on a comparison of white versus black or African American samples of psychiatric inpatients and outpatients and so on. And they saw very little evidence for test bias. What about gender bias? Well, women tend to score higher on this test than men do. The average score for both populations, men versus women, tends to fall in the moderate range if we're looking at psychiatric populations or outpatient clinic populations. Women tend to score higher. Does that mean the test is biased or gives us biased interpretations about women's level of depression? Maybe, but then again, women tend to be more commonly diagnosed with depression than men do. So it really depends. Like, if you believe in the DSM diagnostic system and you believe that it is an accurate, so as to be perhaps a gold standard criterion for what reality is like, then you might say, well, the Beck Depression Inventory is just revealing or reflecting reality. If you think that in general tests and interviews and diagnostics tend to be biased against women because we tend to see psychopathology in women more than men, then maybe the Beck Depression Inventory is guilty or is susceptible to that same bias. It's a tough call, and anyone who studies depression or takes a good psychopathology class knows that it's a little tricky to say for sure. However, I will say at this point that is it biased against women or is there gender bias in this test? Probably not. I mean, the differences between men and women on average are not huge. They do go in the direction of women tending to elevate the scores more than men do. But again, women tend to experience or at least report more symptoms and features associated with depression on average than men do. So far I've really talked about interpreting the total score as a measure of overall depression, then maybe noting someone's particular responses or response sets. I've talked a little bit about cut scores. Now let's talk a little bit about factor scores, which may be useful in terms of characterizing depression. Now, at the point that I'm recording this video, I haven't yet done a separate video. I haven't recorded one. I've made one about factor analysis. But suffice it to say that factor analysis is just a multivariate statistical technique that allows us to look at intercorrelations of responses on sets of items. And what we can do with those sets of items is allow that single or one or two or more factors represent the variance or the covariance of those items. And we can also allow that those factors can, like variables themselves, be correlated or uncorrelated with each other. So over the years, people have done different factor analytic studies with the Beck Depression Inventory, allowing that the factors found within it can be correlated or uncorrelated with each other, most often correlated with each other, so-called oblique rotation, of which I will talk about more in the future. Let me tell you in the next few slides, though, basically what has been found in this type of work. Well, when we've examined different factor solutions in different populations and using different factor analytic methods, for the most part, the solutions tend to be fairly similar. By solutions, I mean the factors that emerge from these types of analyses in these types of studies. They tend to line up. The factors don't always have exactly the same items, but they tend to look at a kind of a macroscopic level roughly the same. So in some of the research that's published in the technical manual for the BDI, they discuss college student populations where the Beck Depression Inventory was administered and then the results were factor analyzed, and there generally seems to emerge kind of a cognitive affective factor which involves all of these items here, kind of the thinking and the feeling of depression, if you will. And separate from it, but correlated, because these are oblique solutions, is a kind of a somatic factor, which corresponds to kind of the feeling or the physical state of being depressed. Things like loss of energy, disruptions of sleep and appetite, loss of concentration, sense of fatigue, and so on. If you look in psychiatric populations, you see a slightly different factor solution. These aren't exactly the same, which has been called the somatic affective factor. So here we've got that feeling of depression, the emotional feeling, if you will, the affect of depression, that kind of links in or correlates with or groups in, I guess I should say, throwing a lot of words out there, with the physical symptoms. And then a separate factor that's correlated that is more of the cognitive features or symptoms of depression. So similar two-factor solution, not exactly the same though. Somatic symptoms in a sense migrate around, in different factor solutions with different populations. That's a little weird, but that just seems to be the way it works. A different study that I found, this is just another publication by Beck and colleagues from around late 1990s, worked with psychiatric outpatients and found, again, this kind of somatic affective factor and this cognitive factor. So again, in the outpatients, the solution is fairly similar. In college samples, it's maybe a little bit different. In general, though, you can see these type of factors emerging. There are apparently underlying factors within this measure, although they are correlated, which sort of, at least in psychiatric patients, separate out the feelings and the physical sensations of depression from the cognitive features of depression. And in college populations, the feelings and the cognitions of depression seem to separate away from the bodily or somatic sensations of depression. A few important points here. These factor scores are useful. I guess I really haven't said how to make a factor score. Really, all you would do is just sum up the values of each of the items within a given factor. Like, let's say you decided, I'm giving the Beck Depression Inventory in a college sample. I want to score up factor scores, so I'm going to use the factor solution that is published in the manual, which corresponds to college outpatient population. I'm going to just simply add up the items that correspond to the cognitive affective factor, add up the number of items that correspond to the somatic factor. Boom, you now have a factor score for each person that reflects each of those sort of separate, although correlated, features of depression. And these factor scores may be useful because they can help you kind of characterize the nature of the depression in your individual client. They may help you track change over time. I think I said this in a previous lecture, but I was on a clinical trial once where I just, for my own curiosity, was administering the Beck Depression Inventory and plotting factor scores for this one client and tracking them in an Excel spreadsheet, which I shared with her. And we saw how over time, apparently, her cognitive, affective, and her somatic symptoms, respectively, changed at slightly different rates. I've said this a few times already, but in these factor analytic studies, a decision is made, or was made in these various studies, to allow that the factors are correlated or that the solutions are oblique. Now that's different from maybe you've read in other papers, if you've taken personality psychology classes, that often there's an attempt to make orthogonal or uncorrelated dimensions of personality or dimensions of temperament. Here we allow that these things are going to be correlated, and in fact they are. So if you see that someone is elevating one factor, however, whatever factor solution you're choosing, they're likely elevating the other one as well. And as you interpret them, you shouldn't think of them as entirely separate, because in some sense, of course, they're really not. A couple more important points. Note, of course, that the factors have different numbers of items, so you can't really compare raw scores, because the cognitive affective or affective somatic factor tends, depending on the solution we're looking at, will always have more items, so a greater maximum value is possible than whatever the other item, other factor is. But what you could do is you could, well, gosh, you could take a z-score, I suppose, but what might be likely is just to track change over time, and you can note extreme differences in magnitude, and note whether most of a person's total score comes from one factor as compared to from another. But again, although we think of these things as distinct, and they are in some ways, in other ways they're really not. So factor scores, you should be a little bit careful about interpreting or really over-interpreting. Certainly you can compare people's scores to the appropriate norm. So you can compare a client score to a population. There's plenty of literature on this. Some of it is published. I'll actually try and link to it on Blackboard for those of you who are interested. In a psychiatric outpatient population, there's some published norms for the non-cognitive or somatic affective factor and the cognitive factor. So if you had a psychiatric outpatient client and you were giving him or her the test, you could then score out factor scores and see where does she lie or where does he lie with respect to what is expected in that population. There are other published studies that use different populations. If you really got into this, you could certainly find quite a bit of literature out there. So far we've talked about the most global kind of general point, which is total score, moved in a little bit deeper to talk about cut scores, moved in even a little bit deeper than that to talk about factor scores. Now, at sort of the very tail end of this lecture, I want to talk about specific items. And I noted these already, but I'm just revisiting them at this point. One, or I really should say two items that clinicians often pay a lot of attention to are item 16 for appetite and item 18 for depression. I'm sorry, for sleep. And the reason why is disruptions in appetite and sleep, when they accompany other symptoms and signs of depression, are sometimes used to characterize a subtype or a form of depression called melancholic depression. So, and that can be useful. So you might want to make note of that if you're kind of thinking ahead to conducting an interview. You might want to ask more about those things, those items or those problems. And you as a clinician might be thinking, this might be a particular type of depression that is worthy of note. I also discussed before that suicide, which is item number 9, but also in some respects item number 2, hopelessness, is well worth noting. You should be making a thorough assessment of suicide risk anyway. That's just a basic standard of care that you should aspire to as a clinician or indeed as a researcher, but especially if you see that someone is elevating either of these two items, or even worse, if they're elevating both of those two items. And generally speaking, I think it's worth noting any other items that have 2 or 3 responses, meaning like the person is selecting the number 2 option or the number 3 option, which are the relatively most extreme options possible. Once the person's done with the test, you might conduct a further interview, or you might select some other tests to administer, and you can think to yourself, I should get back and I should ask about this. This person expressed this extreme sense of hopelessness. I want to make sure I ask about that. Or this person expressed extreme levels of fatigue or extreme levels of concentration difficulty. I want to make sure I ask more about that. This is a screening instrument. It's supposed to help you screen people in, ideally for further evaluation. So use it that way. Don't over-interpret these items. They're just, at best, single indicators, but they can be really useful, provided that you link them up with subsequent testing and evaluation. So, conclusions. What can we make of all of this? Well, the Beck Depression Inventory, 2nd edition, it's a ubiquitous measure of depression that gives us some information about the severity and the nature of symptoms. It's simple to use, of course, and it's generally quite reliable and valid. I talked about that a little bit in my last lecture, and I know that saying phrases like, well, it's valid or well, it's reliable is glossing over a lot of nuance and detail, but generally speaking it is. You look at a lot of literature and you find a lot of support for the use and the appropriateness of the BDI-II in a lot of different settings and applications, especially those that involve screening. And I'd like to point out it's probably a more nuanced test than you realized. Maybe you knew something about this. Maybe you knew a lot about the Beck Depression Inventory, but I think most of us don't, at least when we first encounter it. We think it's, oh yeah, just add up the numbers, that's how depressed someone is. Well, there's more than that. There are cut scores, there are factor scores, which get kind of complicated depending on the population you're looking at or the literature that you're looking at. Which factor solution do you think is most appropriate given this client and the population I think she's a part of, and so on and so on. And then there are all the individual items, which can be useful to a clinician or a sort of a thoughtful, competent researcher as well. Well, that's all for now. Thanks for your attention. This is meant to be a little bit of a supplemental lecture, just adding some additional information to follow on from my last lecture. I hope you found it interesting. I always kind of like talking about the Beck Depression Inventory. It's one of those really just simple, easy, almost fun instruments to talk about. I hope you've enjoyed it too. If you have time, make yourself a cup of tea, cup of coffee, relax, sit and think about this stuff. And if you have questions, please, please, please let me know. All right, bye-bye.